Well, welcome everybody to the public board of the NHS. And I think the first thing I'd like to do is welcome my successor as chairman of NHS England, Richard Meddings, who's on the call. I know he's going to say a few words at the end of the meeting and may indeed chip in during the meeting as well. I've got one apology for absence, which Susan Kilsby is away. And I'd like to particularly thank Munir and Sophia for being on the call. Both of them have got COVID, so thank you both for getting out of bed or whatever you're doing before to join the call. We've got lots of declarations of interest. Has anyone got anything else to declare that's not on the disclosed list? No, thank you. Can we approve the minutes of the last board meeting? Everyone happy? Thank you very much. Right, Amanda, I can't actually see you, but I know that you're on the call. I can just see you now. So Amanda, over to you for the Chief Executive's report.
Thank you, David. And just before I start, can I put on record my thanks, David, to you personally, and particularly for the absolutely unstinting support that you've always given me. And I know I speak for actually my executive colleagues, and I'm sure my board colleagues as well when I say that. And thank you, not to embarrass you, but thank you as well for your just passionate championing of the NHS, of life sciences, of transformation, of innovation, and for your bravery and your challenge, David, when we've needed it. So I think we will all miss you and wish you hugely well for the future. But after embarrassing you for a moment, I will now get going, if I may, with my actual main report. And I'd like to start just by talking a bit about the situation in Ukraine. The suffering inflicted by the Russian invasion has horrified all of us, and I hear from colleagues across the NHS daily about the things that they are doing locally to support Ukrainian colleagues and also to support our overall response. That's been one of the things that, of course, has characterised the way that the NHS has dealt with challenges through COVID and for far longer is the coming together as a service to do what we can to support those in need. And indeed, the NHS has now, of course, taken on the treatment of 21 Ukrainian children with cancer who will now continue their treatment at specialist centres around the country. I know the board will want to put on record our thanks and praise for those involved in their evacuation and ongoing treatment. And we stand ready, and I've again heard this consistently from colleagues across the NHS, we stand ready to assist if the government identify further patients who need our expert help, whilst also, of course, now at the same time preparing for meeting the needs of refugees who will arrive in England over the coming weeks. We've also been working closely with government on medical supplies and support, with several deliveries already made to the region and more planned. Extensive work has been undertaken to assess the level of exposure the NHS faces to supply chain disruption and cyber attacks. I think you know that there are a number of NHS organisations that use products or services from Russian-owned companies not currently on the government sanctions list, and we will continue to support those organisations to manage the latest guidance. One of the most significant issues that it's a continuation of the inflationary pressures, particularly in wider fuel and energy costs. Julian and his team are assessing this impact, and we are in conversation with the Department of Health and Social Care about the potential implications of that on our kind of overall budget. But of course, we're also aware, acutely aware, of the impact the higher costs of energy have at an individual level for our staff, but also crucially for our patients. Specific concerns have been raised with me just in the last week over the cost of electricity bills for those who are dependent on ventilators at home. And we do know that the impact, unfortunately, will be felt much more widely, and experience tells us that this will likely show up through additional need for NHS services. We are, of course, continuing, and it's part of the context for all of our conversation today, to respond to the COVID pandemic. So we've seen an increase, David will say more about this in a moment, but we've seen an increase in patients in hospital with COVID over the past couple of weeks, with some regions actually now seeing their highest numbers since last winter. Vaccination remains our best defence, incredibly effective against in preventing serious illness, so keeping people out of intensive care. And I'm pleased to say that this week the NHS has begun inviting eligible people for spring boosters, and already we've had over 300,000 bookings. So thanks to the efforts of our staff and volunteers, we have protected millions of people at speed, prevented well over 100,000 deaths and hospitalisations since Omicron arrived. And I know that colleagues will once again rise to the challenge. Whilst COVID is still with us, though, we are putting a very strong emphasis now, of course, on recovery. We're going to be talking more about that during the board meeting today. In February, we published our delivery plan for tackling the COVID-19 backlog of elective care, setting out the actions to support the recovery of diagnostics, cancer care and planned treatment between now and March 2025. This is rightly a top priority for the public and for NHS staff too. We are absolutely focused on providing the best possible value for the investment the public are making, and that is why the ambitions set out in that plan are unparalleled in their ambition. It's certainly in my career. And we have here not just an opportunity to make improvements at speed over the next 3 years, but also an opportunity to make long-term improvements for patients and genuinely transform the way that we provide elective care. We have seen the National Audit Office report on vaccines. It was a great reminder that when the NHS has a shared mission and the right backing, it delivers for patients and for taxpayers too. And the same can be true with this challenge. We can talk more about the details and I'll let others come on to that. But just to say, we do know that in seeking not to just do more of the same, but absolutely to use this as that opportunity to transform, technology can really help us make inroads on this too, and embracing new technologies and digital ways of providing care. So we've recently published the MedTech funding mandate for 22-23, setting out 7 new test and treatment devices that we will then support local services to take up. And I have 2 of them here to just to give colleagues a sense of what we're talking about. So this device is a tiny balloon, which I will seek to inflate, if you can see it. It's not actually terribly clear, but there, balloon at the end of this. Now that can go up your nose to get rid of chronic sinus pain as an alternative to surgery in some cases. And then we've got things like this, which is actually slightly less visually appealing, but this is a portable chest drain device which can help patients recover much more quickly from heart and lung problems and also provide accurate monitoring. And then things like, a burst of steam that can shrink an enlarged prostate. So these cutting edge devices, they might be small in size, but these are the sorts of things that will make a huge difference to the lives of tens of thousands of patients every year, as well as freeing up time for NHS staff. And these cutting edge devices show how the NHS is embracing the latest life-saving technology and rolling it out at speed for patients across the country. Further work is taking place to deliver the recovery of services, of course, and we're going to talk about this in the board meeting today, across urgent and emergency care, primary care, mental health, community services, because they're all connected. So, the way we have to think about this, we can't isolate just elective recovery as a thing on its own. We've got to see it in the context of that overall recovery, although rightly picking that out as a real priority for the public. Urgent emergency care does continue to be under particular pressure. The same is also true of mental health services, where they're particularly dealing with a significant increase in demand. So we've got crisis referrals up 74% compared with 5 years ago. So predictions that COVID would leave behind scars on mental health were clearly well founded, and responding to that is going to have to be a key priority, not just for the NHS, but for wider society too. We also have ongoing improvement challenges, particularly, I just wanted to talk, if I may, for a moment about maternity services. So at a national level, we've made progress on key measures over recent years, and I'd just like to thank in particular Ruth for her leadership on this. But there are still too many heartbreaking examples of when families haven't had the quality of care they need and should expect through pregnancy and birth. There's a lot to do, and we remain totally committed to that improvement task. We've received the interim report from Donna Ockenden back in December, and already all services are reporting progress on the actions which came out of that, and we're expecting the final report from Donna imminently. And I know Ruth and Jackie Dunkley-Bent are ready to swiftly follow up any further recommendations with our support and the support of the whole board. Ahead of that, we have agreed a funding package, 125 million, to further boost capacity, quality and safety across maternity and neonatal services. That multi-million pound funding package will build on the significant steps we've taken in recent years to transform the care for pregnant women and their babies. But I think the message from me, David, is we will not hesitate in taking further action to learn, improve and ensure all women who use maternity services receive the best possible care. We know workforce is going to be central to this, as it is, of course, across all of our recovery and transformation priorities. And we're working closely with colleagues at HEE on scoping a workforce strategy. It's clear that's not just about numbers, that we have an opportunity to reform how people work, freeing up staff to do what they do best and finding new ways to allow those who can and want to contribute to do so. The NHS Reservists programme announced in February is a great example of this, as is the new programme we launched over the weekend to support experienced midwives to stay in the NHS and to support the midwives of the future. This really is a vital programme of work, and one I know we'll be discussing more at future meetings. Worth touching, if I may, just briefly on some other key developments. Firstly, colleagues have been working closely with the Department of Health and Social Care and with the Secretary of State personally on his reform agenda. A major theme of his speech was giving, so Secretary of State's speech recently was giving greater control and choice to patients over their care, building on the themes from the elective recovery plan and the success of our work in personalised care. And again, I just want to give credit, if I may, to James Sanderson and his team for everything they have done on that over recent years. The speech also included a commitment to supporting NHS trusts to collaborate more effectively to improve care for patients, and we will be engaging with local leaders over coming weeks on how they can make full use of the freedoms and flexibilities provided by the Health and Care Bill. The government also set out its plan for living with COVID, and we're working with DHSC and Treasury on what that means for the NHS. In particular, we're looking at what the decision to fund ongoing testing from within existing DHSC resources will mean for the NHS budget in 2022-23, and I think Julian may well want to say more about that when we talk about the financial position a bit later. And finally, we have continued to work effectively with the life sciences sector to make new and effective treatments available to NHS patients who would benefit. Again, we're going to talk about that later, I hope, in a bit more detail, but just over the last 2 months, that's included new life-extending treatments for patients with multiple myeloma, womb or endometrial cancer, MLD and lung cancer, providing new hope for patients at a fair cost to the taxpayer. So, David, thank you again on a personal level and a professional level, and thank you from me and from all of us, I think, to everyone in the NHS who is just working so hard across the whole of our services to deliver the best we can for our patients.
Thank you very much, Amanda, and thank you for the kind word you said about me. I will regard the most important thing that I've done in my time actually was to see you appointed as Chief Executive of the NHS, Amanda. So you're doing brilliantly. So look, I'd just like to bring in Ruth if I can here, because you know, the board has flagged the overriding importance of getting maternity and neonatal services right, and we're well aware of the failings that have happened in a number of hospitals over a number of years. And Ruth, you've been looking at this very carefully. Would you like to comment on that?
Thank you very much, David, and thank you, Amanda, and thank you to the board for supporting further investment into maternity services across England. But let me just start by being grateful again, like I did say this time last year, to the families that have been voicing their concerns. They had the courage to ensure that their voices were listened. And thank you too to Donna Rockenden for her leadership of this report. But trusts across England have really driven improvements. They have worked so hard to improve the maternity services, investing, using the investment that we gave them this time last year, the 95.6 million, but also increasing the investment that they have made too. So if you think about this time last year, we said we wanted to invest in 1,000 additional midwives. I'm pleased to see that right now we've got an additional 1,560 midwives in the establishment, and the same type of improvements as well, investing in obstetricians. But actually now we need to make sure that those posts are filled. So that's why I'm pleased to see that with HEE's leadership, supporting more and more people come on to do their training in midwifery, and indeed HEE's leadership supporting more obstetric doctors in training. But we also now need to continue the success we've had with international recruitment for nurses and to apply that for international recruitment for midwives. I say all of that though, recognising that there is still much more to do in maternity improvement, much more across organisations in England. But thank you for the investment you've made again today, because these investments will make a difference. And I'm particularly pleased this time to see the investment in capital for neonatal services, because that's really important. So I will look at the report that Donna Ockenden publishes next Wednesday in absolute detail, line by line. It will be heartbreaking reading, I'm sure, but one that we focus on.
Thank you, Ruth. It is an absolute top priority for the board, as you know. Andrew Morris.
Thanks, David. Ruth, you've done some really fantastic stuff around trying to get more people into the service, both midwives and consultants. But could you say a bit more about the work you've been doing around developing cultures in some of the kind of poorer performing maternity units, please?
Yeah, thank you, Andrew, because we know that culture is sometimes very deep rooted, and it's for me, there's several parts of it. There's the leadership work, leadership and supporting our leaders, our midwifery leaders, our consultant obstetric leaders, our operational leaders, our board leaders, to make sure that they have the time to do the leading as well as the environment to lead in. And I'm pleased that the investment that we are announcing today will support some more time for our clinical directors to have the time to lead. We have, of course, during this year since Ockenden 1, since December 2020, been really investing into the regional infrastructure and, of course, infrastructure into the trust themselves to support their frontline staff. So we've been investing in £50,000 per unit so that we can make sure that we are supporting those newly qualified staff, those people that are doing the midwifery on the front line. We've also, of course, that part of that funding last year was to do some of that multidisciplinary training. We know that culture improves when people are working together, training together, learning together, and that is really important. But of course, removal of one of the blockers has to be about workforce numbers. We do need to increase the numbers of midwives and obstetricians and maternity support workers. And that we've now seen the big investment with the establishments. We've seen some increase, but now's the next year has to be about really filling those posts, as well as then supporting the people that we've got in post to keep them here.
Thanks very much, Ruth. Well, I think your hand is up.
That's right. Thank you, David. Ruth, thank you for the comments you're making. Could you just say a little bit about the data collection efforts you're taking and making? Because, of course, being able to measure, understand what's going on across the piece helps you to sort of focus on not just the ones that aren't doing well, but the ones who are in danger of not doing very well.
Absolutely. So we have moved from a position of waiting for people to be rated red. rating by the CQC, an adequate rating by the CQC before taking action, to really making sure that we've got the maternity support programme in place to support those organisations that are struggling. Now, of course, we've got some of the data collection tools that help us to look more upstream. So making sure that we're supporting those organisations that may be struggling in the future. So that is that surveillance, that real-time monitoring has been really important. I'm grateful too for the leadership that Sir David Sloman has given to this as well, supporting the regional directors and regional teams coming together to review the data, where they all with the Donald Rockington actions from 2020 report, where are we all on what the outcome data is telling us, so that we can really triangulate this and get upstream. Much more to do, and this is taking a lot of focus, a lot of time of boards, but let's make sure that we encourage boards to continue to focus on maternity services as they have been doing over this last year.
Thank you very much, Ruth. I think we should move on now to the operational report. David Sloman.
Yes, thank you, David, and good afternoon. So as ever, David, my report covers all areas of operational activity, including our response to COVID, elective care, urgent care, diagnostics, cancer, primary care, community services, learning disabilities, and autism and screening. It's all there within the report. I'm quite happy to take questions on any of it before we hand over to Julian to discuss the headline financial position. As we're aware, later on the agenda, we have Jim Mackey joining us to talk about the elective recovery programme. So I will just touch and focus on two areas, David, although, as I said, I'm quite happy to take questions on anything in the report. Firstly, as Amanda has headlined, just to share with people where we are with COVID and the impact of the COVID pandemic on the NHS. Currently today, we have 13,248 beds across the UK who are occupied by a patient who has COVID, which is a 60% increase in numbers over the last 3 weeks. Of those people, 43% of them are admitted for COVID and 57% with COVID. So that has been a change in the profile of the admissions compared to previous waves. Of course, as a consequence of the pandemic as well, we have 3.5 million people across the UK who have COVID, many of whom are our own staff. So one of the major risks here, of course, is sickness and absence associated with our staff contracting COVID. The two things I would nonetheless say, what is different from previous waves, 2% of these patients in those beds are in intensive care, whereas in previous waves that number would be nearer to 20%. So it's a very, very different presentation. Therefore, we are seeing a shorter length of stay. And also, we have learned as we've worked our way through the waves of COVID. I'm pleased to say that when we come to Jim's report, he will be able to say that much elective capacity and elective performance we've managed to keep on the road. So we've managed to keep, I think, almost 95% of RTT completed pathways have been undertaken during this wave of COVID when compared to business as usual. First cancer treatments are 102% of business as usual during COVID, despite the pressures in our system. So a system under pressure, but a system that is working to keep the elective and planned care show on the road. The second area I would highlight is, again, as Amanda has mentioned, we have been under and are under real pressure in the urgent care pathway, as is evidenced by our 73% performance against the 95% standard, and also the challenges that we face in the Category 1 and Category 2 ambulance performance. So in response to that, I have led a series of meetings with the chairs and chief executives of all trusts and all integrated care boards and systems across all 7 regions. During the course of the week, we have held 4 sessions so far. 3 are due to be held tomorrow. And we have been collectively asking systems to collectively focus on 4 things as systems. So we have asked all chairs and chief executives to produce plans to think through how they will collectively share and manage the level of clinical risk that we are facing across the system in the round, and to be clear within those plans the trade-offs and the nature of the risks associated with those plans, so we are clear of the consequences of the plans that we are making, and if we need to discuss them with relevant regulators, that we will do so. And that is an all-system, all-play plan that we've asked for. Secondly, we've asked all systems to ensure that when a patient has completed the care that they need to receive in an ambulance in an accident emergency department, they are rapidly moved on to an appropriate care setting, either within the hospital or ideally and hopefully being discharged back to their home. That thirdly, systems plan that the discharge performance on the level 0 pathway on the weekend is as good as the performance during the week. This is something we struggled with for many years, but I think is a real priority at the moment. And finally, that all trust boards regularly on their daily, weekly, monthly routine meetings look regularly at the data associated with Category 1 performance and Category 2 performance and the hospital handover performance, all three of those targets, and that they are responding as a consequence of the data that they are looking at. So I'll pause there, David, but that's been a real focus of the senior leadership team during the course of the week. I've been actively supported by Steve Parris and Ruth May and indeed Pauline Phillip in these meetings. They've been extremely well attended, and I'm absolutely clear that people are focused on this as an urgent priority across the system. But I will pause there, David, for any questions.
Yeah, thanks, David. Before we have any questions, should we just bring in Julian, just on the finance side, and then we'll pick up the questions to both of you, maybe. So, Julian.
Thank you, David. Again, I'll assume the paper is read, but the headlines basically for 21-22 are in the paper. At the end of month 10, we were forecasting to underspend the total revenue budget of 150.9 billion by 640 million pounds. I anticipate that by the time we actually get to the end of the year, that will be slightly higher at about 1 billion pounds, but less than a 1% difference against the total spend. Principally, the reason for that is that, I mean, undoubtedly we can see provider organizations having to control spend as they prepare for a total real terms cut year on year in funding from 21-22 into 22-23. So they are having to manage that glide path. Two, undoubtedly, Omicron has meant that we have done less elective work than we would have hoped. I mean, it has disrupted the NHS through the winter and taken out capacity that otherwise would have been used for elective care. And that has also reduced the sort of marginal operating costs. Three, there is some slippage in some of the kind of transformation programs that were planned. I mean, for example, in primary care, the recruitment to additional roles has probably, been slightly slower over the year. They will hit the endpoint goal just because our GPs have been so busy. I mean, and fair enough, vaccinating and treating patients. And then for actually along similar lines, we had put extra investment into primary care with the government decision to accelerate the vaccine program. In fact, that funding has sort of come from the vaccine program, and the extra capacity has been used vaccinating the very successful program over the winter that the NHS carried out. So that's the position for this year. Just on capital, I mean, pardon the pun, but we will basically land on the money. I mean, we will be, within about 20 or 30 million on about £6 billion spend by the time we end the year, which is, I mean, actually an incredible job when you think of everything that trusts have had to manage through this year, but keeping going with the programme of investment in change to try and safeguard the estate and transform services. I'm going to flag, though, as we just look ahead to 22-23, the NHS is currently still engaged in the kind of planning for 22-23. But since we put out the initial planning guidance, and indeed since the original agreement with government on the funding for the NHS last autumn in the spending review, I just want to flag a few changes. Number one, as a consequence of needing to find funding to deal with the government's Living with COVID plan and the cost of the kind of public health policy around test and trace, we have been asked to see if we can cut core NHS funding. At the moment, that is probably to the tune of about £500 million. And we are working through options, but largely that would involve slowing down transformation programs and a rephasing of some of the kind of long-term plan changes that we had been talking about. Two, clearly, as flagged in the Chancellor's Spring Statement yesterday, inflation is also running much higher than was assumed in the spending round, and clearly that is going to have a knock-on effect to the NHS. At the moment, we're just working through the implications, but that could equally be materially over an additional £1 billion pressure on the NHS. So, I mean, significant changes, and we're going to have to look at what that means for our ability to deliver, you know, sort of NHS goals in the round. I would also flag, in fact, we spoke about it earlier, the ending of the hospital discharge programme. I mean, the government chose not to fund that going into 1920. That has significantly helped flow through hospitals and support into the social care sector. And the ending of that, as of the beginning of April, the decision by the government not to continue to fund that will mean that is going to have a knock-on impact onto emergency care performance, which David was just talking about, and some of the challenges that we have got. So, you know, again, we're working through what is the impact and how do we manage that across the NHS. I think I'll stop there, David.
Thanks, Julian. I wonder whether David Bean, you'd like to comment on this delayed discharges from hospital, the transfers of care into the social care sector.
Thank you, David. Thanks, Julian. Yeah, as Julian pointed out, David, I think the consequences, the additional money has been massively important in actually assisting people coming out of hospital and being supported in social care. So I think it will have a double knock-on. It will have a knock-on directly to social care and the implications there, but also, as Julian has outlined, the implications for just easing the flow in hospitals, and that knock-on back into urgent and emergency care is likely to have an impact back into elective care as well. So the degree of risk by that funding being reduced is a real and significant one.
Thanks, David. Any other questions on the operations? Andrew, you had your hand up. Andrew.
Yeah, thanks, David. Thanks, David Sloman, for the 4 key initiatives, which I really strongly support. I think they will start to make a difference. It'd be good to just better understand the proportion of social care delays to health delays and that gearing, because I think most chief execs are saying anecdotally to me that, you know, they've got 3 or 4 wards worth of delayed discharges in a typical DGH. So it'd be good to just better understand the split, just picking up on David Bean's point around the social care element.
Okay, thank you, Andrew. So the way we look at the hospital delays are broadly in 4 categories. Firstly, the delays which are actually responsibility of the internal management process of the hospitals. And as you will be aware, we're doing a piece of work led by Leslie Watts around this in recent weeks, which has managed to reduce those delays by 69% across the 14 hospitals that we've been working with. And we are now thinking through how we can generalise that work out into the rest of the system. The second 2 are associated with delays broadly within the control of the NHS about the interface between primary and secondary care, for example, and also the amount of community capacity we have in place to support flow in the round. And fourthly, which of those are more associated with social care, be it residential care or domiciliary care. The split around that is where we're actually trying to absolutely nail it down, Andrew. So I wouldn't say we are definitive about what that split would look like. I think it broadly balanced towards pathways 4 as opposed to 2 and 3, and that work is being worked through at the moment.
Thanks, David. We'll take 3 more just very quick questions if we can from Munir, Laura and World. So Munir, you first.
Yeah, just trying to understand the reasons for the increased demand. Part of it is COVID, but not all of it is COVID. I'm sure you've done a deep dive on this, understanding what the reasons are for the increased demand, but also what the geographical variation is in that demand, please.
Do you want to take all the questions, David, and I'll come back?
Yeah, okay, let's do that. So Laura and Wal, please.
Thanks, David. I wanted really just to sort of probe a bit further on what we're doing in the space of mental health, where we know that there's been this huge increase in demand, and how we are trying to address that. Thank you.
And Wal.
Thanks, David. And David, I'm just interested in urgent emergency care. Obviously, workforce is an issue with some COVID-related absences, but what else can we do? And how are we tackling those particular trusts that are really troubled when it comes to ambulance discharge?
Thank you. Well, perhaps Pauline, I'll bring you in on the work that we're doing with the 35 trusts who are particularly challenged. But in terms of activity, by and large, in the urgent care pathway, it's a slight generalisation, but demand in the urgent care pathway is getting back to pre-COVID levels across the piece. There's slight variation between the regions, but by and large, it's pretty similar. So we are getting to about pre-pandemic levels of emergency care activity in all regions across the round. In terms of mental health, Laura, you're absolutely right that Amanda has highlighted the pressures in the adult, I think, crisis service and demand for adult mental health services. I would flag that there are similar challenges within the child and adolescent mental health pathway in terms of young children who are in need of mental health care. This work, as you'd imagine, is being ably led by Claire Murdoch and colleagues. They are working through right across the piece about how they stand up and ramp up those services, both to deal with that emergency demand, but also to deal with the backlog that has been accrued over recent months. So perhaps, Laura, next time around when I do my report, I'll bring up front perhaps in more detail onto where we are with mental health recovery.
Pauline, are you going to?
Yes, I just say a little bit about the 35 hospitals that have the most significant problems with ambulance delays. So I think the first thing to just say there, David, is that when we're looking at the Cat 1 and Cat 2 performance and the deterioration in it, we feel that there is a very real link between those delays and what is happening with the handing over of patients once they arrive at hospital. And that's obviously what's linking through to the pictures of people in ambulances outside our organisations. So what we did was identify the 35 hospitals that appeared to have the biggest problem, and it's bringing together the ambulance trusts and the hospital trusts to tackle the issues. So some of the work has been focused on out of hospital, basically supporting the individual ambulance services when they go to people's homes, looking at see and treat, hear and treat to avoid conveyancing. And we've done very well on that. The level of conveyancing actually into hospital now is much lower than it was pre-pandemic. But once patients are actually brought to the site, and there's a whole set of processes and initiatives that we've been working through. First of all, looking at the staffing within the departments and clearly the staffing along the emergency care pathway. Looking at the processes within the emergency department, how it's staffed 24/7 and not just during 9 to 5, 9 to 6, etc. Looking at IPC and how the IPC measures are being implemented in the most sensible way possible, making sure that the testing that we're having to do from a COVID point of view, again, is done as productively as possible so as to avoid patients being delayed further in the department. And then, of course, into the hospital as far as discharge is concerned, and in particular, making sure that discharge rates continue on a Saturday and a Sunday. So by doing all of those things, it's helping with the flow and therefore allowing us to take patients quickly when they arrive in a hospital, etc., by ambulance.
Thanks very much, Pauline. Look, Laura's raised the question of mental health. I mean, this is a huge issue that we're all hugely conscious of, Laura, particularly the rise in young people's mental health problems. We can't do it justice today. What I would like to suggest, maybe, and it's not up for me, it'll be for Richard, but maybe you bring back mental health as a separate item at maybe the next board meeting, because we can't do it in 5 minutes. It's so important. And so if it's all right, Laura, can we put that off for another day? But let's not lose it, though. It's very important. So look, can we
Dave,
move
we'll
on
pick
to
it
the
up at the next board.
And
We'll pick it up at the next board.
Okay, thanks very much. So look, we've got Jim Mackey with us. Jim is an old colleague and good friend of me and many other people on the call. He runs one of the best performing trusts in the country in Northumbria. He's been the chief executive of NHS Improvement. He has stepped up when he had no real reason to step up, in a way, to lead the elective recovery programme. And Jim, you've been a real brick, if I can put it that way, a real supporter of the NHS, a real supporter of Amanda and her team. So delighted that you're with us, Jim.
Thanks, David. Yeah, I really appreciate the comments, and it's been an interesting few months on this programme. So I'm just going to walk through the report, if that's okay, and I'm sure Pauline and other colleagues will chip in as well when appropriate. So hopefully everyone's had a chance to read the report. Since H2, the half-year point when I started getting involved, we've had a huge focus on long waits. Those waiting 2 years mainly, and that's really stepped up over recent weeks with very significant progress aiming for the end of March to minimise those patients waiting over 2 years, and then into July in the new year. So massive progress there. I'm sure Pauline will talk about that in a bit more detail when I finish the summary. But we're also trying to build systems for the future as well, and make sure that people are planning for a more sustainable recovery in line with the National Recovery Plan. And as David and Julian have mentioned already, that's a work in progress as trusts and systems work through their planning processes. So we haven't fully digested the outputs from that yet, and we'll do over the next couple of weeks. The focus on long waits has given us the opportunity again also to test our approach to choice and how we can help move patients around systems and the country if necessary, where it's going to be important to help get them their treatment. So trialing that in the southwest, and then it will be developed further in the organisations with most 1 or 4 week waiters, and then over the coming year increasingly expand choice at the start of pathways where it is easier to influence choice and make the systems more robust and more systematic going forward. And we've had a huge focus on outpatients, which again I'm sure people have been aware of, but the vast majority of waiting time experience won't involve an inpatient stay or surgery. The thing that really does influence patient experience and impact is the outpatient sphere, with roughly 80% of clock stops happening there. And we also know that there's a huge amount of transformation possible there, the ability to engage patients better, give them more choice and control over the pathways, engage with clinical teams. And that's being worked through in every organisation now, being led by some pilot sites, about 20 organisations who are working together, and we'll publish sometime in the next few weeks some of the outputs from that, the experience and the learning to hopefully accelerate development across the NHS. As David Sloman mentioned earlier, the NHS has coped incredibly well by managing to maintain an awful lot of access during the heavy winter months and peaks in COVID. That's especially complicated again just now, as we've had the rise in COVID infections and occupancy, and colleagues around the country are having to do all of that juggling, but have managed to maintain a very good level of access relative to other waves that we've been through. But we should absolutely acknowledge it's very, very difficult out there in urgent care, the impact on discharge and social care, and generally the constraints that you have when you find patients are COVID positive, and also increase in staff absence, which can disrupt pathways significantly, especially last minute absence. So there's an awful lot of juggling going on there. For about the last 6 weeks, we've seen steady progress on all of the long wait metrics, so very strong progress on those waiting 104 weeks and 52 weeks. The 5 organisations we've been working most closely with, who've got most of the long waits, have again all improved over the last few weeks, so really strong progress there. Our main challenge currently is we can't quite get to the activity levels that people really want to and need to deliver sustainable improvement, largely because of that COVID occupancy, discharge pressure in the urgent care pathways has been discussed previously. But overall, I think really strong initial progress. We've got an awful long way to go. People are starting to recognise and understand now that this is a long-term process. This isn't going to be finished in a few weeks' time. So we need to really build sustainability into the system. But I think we do need to recognise and acknowledge the efforts of colleagues across the country in very difficult circumstances. So very happy to open it up and take questions, and also bring Pauline in, David, if that's okay.
Thanks very much, Jim. So while people are thinking about any questions they want to ask Jim, Pauline, would you like to say something?
And David, I think really the only thing that I would want to add to what Jim has said is just to acknowledge the amazing work that our staff have done. You know, we've set out in the paper that at the start of the year, 400,000 patients could have been waiting more than 2 years by July, and we genuinely believe that we will end up in July in a place that the only patients who will be waiting will be a small number who choose to wait because they don't want their care to be transferred to another consultant or to another organisation, and then a very small number of patients where they need super specialties to be involved, and we genuinely haven't got enough clinical cover in those areas. So I think that's it's a massive acknowledgement of all the hard work that's been done. I think the only other thing I would say is to just support what Jim said about capacity. I think Amanda started in her report explaining that even though we're back to a bed base similar to what we had pre-pandemic, as long as we have the COVID numbers that we have, and we obviously have to do take the IPC measures, that we have a significant constraint on our beds. And I think organisations are doing really well from an elective point of view, being able to deliver P1 and P2 work, clinical priorities and long waits, but it's very challenging.
Thanks, Pauline. Andrew?
Thanks, David. Thanks, Pauline. Just a question for Jim around innovation, and how do we spread the good practice of some of your exemplar sites, Jim, and get it adopted right across the NHS, because the NHS has got not a very good track record for adopting best practice and innovation. So how are we going to spread it as widely as possible? Because no doubt you'll come up with some really good ways of working differently.
Yeah, it's a great question, Andrew, and it has been historically a terrible weakness of ours in the NHS, sharing good practice. It came up, we did a round of chief exec calls in January, I think it was, and it came up very strongly in that process where people wanted to have something a bit more formal where good practice could be shared. We've actually got colleagues within NHS England now working on a proposal or with 2 or 3 options as to how we can do that using different digital platforms. There is a lot going on anyway. So I mentioned the outpatient thing where there's an informal network of about 20 organisations are working together there and comparing, sharing good practice, etc. But to industrialise it, make it much more visible and easy to do. And I think really importantly, engage clinicians in it where they're able to post a good idea, share a good idea, ask a question. Maybe I've got this problem, has anybody dealt with it before, kind of thing. We're going to really struggle and it'll feel quite kind of homespun and sporadic. So within a couple of weeks, we'll have 2 or 3 options that will say, we can do this in a digital way that will be accessible across the whole of the NHS. We need to choose the best way and then go live sometime early in the new year.
Thank you.
Jim, you've always been an exponent of separating planned surgical care from emergency care, I think. I mean, is that going to play a big role going forward in your view?
Absolutely. I think it's absolutely essential. And I think we're proving it today, David, with all of the juggling that's going on in urgent elective care currently. There's lots of variations on it as well. So I would say there's a bit of debate in HSJ last week about whether there was only one way of doing it or not. We've got a very specific way of doing it here in Northumbria. I think it's about the principles really, and about working through your own thoughtful process locally that gives as much resilience into the different streams as possible, so that one doesn't contaminate the other. And that can be done on existing sites by adapting existing premises if you get the workforce model and the clinical models right. And in other places, it can be structural reconfiguration where you create proper, formal hot and cold sites where there's no non-elective activity going on the elective sites. It's supported by our investment in H2, and it's also a big part of the TIF investments as well that are currently being assessed and evaluated. But it's absolutely a very important principle, David.
And do you think that the community diagnostic hubs are, they're part of almost the same kind of argument, aren't they? Not quite, but yeah.
We are, absolutely. So again, speaking of the system I know best about, our current system never has anybody waiting or made to wait in an elective pathway because an emergency patient comes in and trumps them. It happens in different places with different staff and different kit. And I think if we can get to that point where clinicians aren't having to juggle and then cancel last minute and send people home, we're never really going to be able to work at the pace that we really need to be able to. So the community diagnostic hub process, again, there'll be different flavors of that. It'll work differently in different places. The principles are absolutely essential.
Well, Jim, I remember Amanda telling me right early on when she was appointed, there was one person that she could persuade to take responsibility for the elective programme, it would be you. And I can't think, as soon as you agreed to do it, I think a huge sigh of relief, Jim. We could not have found a better person. So look, on behalf of the board, all of us, thank you very much for stepping up and doing it. Fantastic.
Thanks, David.
Thanks very much. Thank you. Right, moving on then to Ian.
Thank you. Just a brief update on the Health and Social Care Bill. So 3 pieces of welcome news. Yesterday afternoon, the bill completed its 3rd reading in the House of Lords. So it's very much in the finishing straight now and the end game. I think the first piece of welcome news is the continued confirmation of the Secretary of State that whilst the timetable is getting a little bit tighter, we should continue to plan for ICBs to assume a statutory mantle on the 1st of July. And so systems should continue to press ahead on that basis. Secondly, that all of the core propositions that these boards jointly made to government in September 2019 not only have been transcribed into legislation, but have passed through both houses and have basically been agreed by both houses and are not currently under debate, which I think is excellent news. And then the third point is that, wonderful as our propositions might have been, they were clearly not the last word. And the bill has been very significantly improved by the second chamber during its passage in a number of areas that are profoundly helpful to NHS England and improvement. Most obviously, but not comprehensively, in relation to net zero and healthcare inequalities. And then my final kind of observation is that, look, there are still a number of issues under discussion between both houses. Commons consideration of the Lords Amendment 30th of March, and then it returns to the Lords 4th of April. And there are 2 items, I think, that would be remiss of me not to mention in terms of stakeholder interest on this, which relate to the defeats that the government experienced in relation to transparency on workforce planning numbers and on new service reconfiguration duties and powers. And obviously we wait with interest, as do our stakeholders, as to how those 2 items end up being resolved. So the boards are invited to note where we are at the moment. Thank you very much, David.
Thanks, Ian. Any questions for Ian? We're now 5 minutes ahead of time, actually, which is I thought we were running behind time. But is there no question for Ian? Okay. Have our guests arrived, Sophia, for the next session on life sciences?
Not all of them, David. So you got Peter with you and Blake, but we're still waiting for Dr. Sam Roberts, Professor John Bell, and June Rain.
Okay. All right. Okay. Well, will you let me know when they're with us?
Will do.
Okay. Thanks very much. I just wanted, we've got a bit of, as we have 5 minutes before the next session on life sciences. Just going back maybe to the David Sloman's sort of report on operations. Are there any further questions anyone would like to raise about the operational performance of the NHS at the moment? I mean, it's just worth mentioning maybe that we had 3 chief executives, as most people on the call know, with us yesterday evening. And it was Sam Higginson, I think, from Norwich, where of course I spent quite a long time at Norwich. And I remember we built the new hospital, and the same day admissions unit literally had a wall around it because we wanted to keep it separate from the rest of the hospital. But within a year, we'd knocked a hole through the wall so that the orthopedic surgeons could get at the facilities at the same day admissions unit. And I was thinking that in the context of planned care, how hard it is to actually ring fence elective care within a busy hospital. Even if you build a wall around it, the temptation to knock a hole through it is compelling. You almost have to be on a separate physical site. I can see Andrew Morris sort of nodding there. Is that your experience as well?
Absolutely, David. And in my old trust, we made a decision to keep elective surgery separate at Heatherwood Hospital, and that facility is almost finished. It's a £100 million investment, and that will provide orthopaedic services and ophthalmology services to the wider community, say 800,000 people, and people can get booked in and know that they're not going to get bumped. And it will be, working absolutely flat out 7 days a week. And it's that kind of re-engineering that needs to take place where there's opportunity to do so. And that facility, I believe, will open at the end of this month.
Thank you, Andrew, for that. And David Bean, you've got your hand up now.
Yeah, and sorry, David, I should have said this when you invited me to comment earlier, but it does relate to the question you've just asked and you've been raising with Andrew, and it was particularly prompted by the 3 chief executives yesterday evening, that actually what the current position does puts a real emphasis on the importance of collaboration at a system level and at a very local level, not just between acute and primary and community care, but between acute, primary, community and adult social care. And whilst the funding has ended on delayed transfers, the importance of using the opportunity created by ICBs to bring partners together at a local level and at a system level is really the antidote, I think. And what I took from the discussion last night is it just reinforces the importance of collaboration between local partners at a local level and the essential nature of developing that. And I just wanted not to lose the opportunity. I missed it when you invited me earlier, but this 5 minutes gives me the opportunity to repeat how important that is. And I think we're intending to bring together chief execs and chairs of ICBs, and I think that's going to be a really important conversation about how we combine responding to the pressures that David and Amanda have just taken us through in their report, and Jim has eloquently talked about, with some of the ambitions I think ICSs will have about improving population health. And it strikes it's not an option between doing one or the other. It's not a binary choice between the here and now and the longer term. It's actually how we encourage a combination of both. And I think it's probably just worth in the public board taking that opportunity to reinforce those messages. Thanks for being in front of the agenda, David.
Thanks, David, and thank you for speaking so long and eloquently to fill the gap. Appreciated. Are we all here, Sophia?
Yes, our guests have all joined us.
Excellent. Okay, well, the next item on the agenda is the life sciences, and I'm going to hand over to Tim Ferris, who is going to be the master of ceremonies for this part of the meeting. But I would just like to say hello to Blake Dark, who heads up medicines in the NHS, has done an astonishing number of highly innovative deals, and I think completely changed the reputation of the NHS amongst the biotech and pharma and sort of medtech community. Got Matt Whitty, who's the chief executive of the Accelerated Access Collaborative, who's doing a remarkable job in spreading innovation across the NHS. Got Sam Roberts, who used to be with us, of course, at the NHS, and Sam has literally just become the chief executive of NICE. Many congratulations, Sam. We're delighted you're back in the ecosystem, almost back in the fold. We've got Peter Johnson, the National Cancer Director, who's done a fabulous job, Peter, in introducing new early diagnostics and cancer treatments into the NHS. And June Rain, who's the chief executive of the MHRA, and June has completely transformed the MHRA as an innovative, agile regulator since she took on the job just over a year ago. And we've got Sir John Bell, the Regis Professor of Medicine from Oxford, who has led the life science strategy for the government for probably more years, John, than you would care to remember, I would guess, but has done a truly remarkable job in supporting British life sciences. And of course, we've got Aradazi, who we all know being on our board, who is also chairman of the AAC, and in his role at Imperial is one of the great figures in, along with John, in not just British life sciences, but in global life sciences. I think John and Ara stand as giants in that field. So I'm delighted that they are both with us today. And Tim, I'm now going to hand it over to you to take it on.
David, thank you so much. It is a great pleasure for me to introduce this paper. I'll just say a few words about context, 3 points about the paper, and then I really look forward to the comments of our guests, because that's really the key piece of this. So the future health of the citizens of this country depends on the NHS and our partner organizations executing on a few key priorities. And actually, David Behan's comments about the long and the short, doing both, were spot on. We have spent quite a bit of time today reviewing some of those short-term priorities, and now we're going to spend a little time on the long-term priorities. This board and the Secretary of State have endorsed finished digitizing the NHS. That's a really important part of the enabling factor that allows the research to occur at the very tip. We need to connect our source operational systems to each other and interrogate that combined data for information that will help us. Information that will help citizens care for themselves and access NHS services. Information that will help the NHS improve outcomes and reduce health inequalities by providing proactive, personalized prevention. Innovation that will help us managers and clinicians identify opportunities for improved efficiency and less friction. And information that will help and enable researchers and commercial partners to discover and develop new diagnostics and therapeutics amid our society's, or against our society's most pressing health problems, including especially cardiovascular disease, mental health, dementia, respiratory conditions, and cancer. That is the life sciences vision. This paper is a high-level overview of current initiatives to improve our partnerships. And while I have the honor of introducing it as a relative newcomer to the NHS, I have had less to do with any of it than the terrific team assembled here today. All of our guests have made it their mission to make sure that this country is doing all it can to capitalize on its assets in order to make large gains in the population's health. 3 points about the paper. The paper is a product of many people from multiple organizations. Innovation is a complex ecosystem that depends on regulators, academics, commercial partners, and the delivery system coordinating and rowing in this. All of those need to be rowing in the same direction. I think we're making really good progress. The reference to a learning health system was in the paper was intended to underscore the dual importance of innovation from within and innovation from without. They are both essential. Our own workforce are best positioned to show us the way, and our platform called Solving Together is just one example of how we are encouraging that the frontline healthcare workers, clinicians, managers to build solutions to our most pressing short and long-term problems. Engaging the workforce in and empowering the workforce in transforming our care pathways is one of our key levers for addressing burnout. At the same time, we must not only be open to external partnerships, but actively encouraging them. Science is advancing rapidly, and the NHS should be the leading organization in the world for bringing that science to the benefit of its citizens. The work in front of us will be very challenging and require a shift in both perspective and how we are organized. Even as we thank the visionary leaders who have taken us to this point, we will need to work hard to maintain focus and momentum. Most importantly, we will need to approach each novel situation, and as Blake and Matt will be the first to attest, every one of these new partnerships does present us with something we have never encountered before. We must approach each novel situation with a can-do attitude, the same attitude that delivered the vaccine program. Innovation must be viewed as an opportunity that we cannot afford to pass up. So before I ask each of our guests for comment, I want to add my voice to Amanda's and those others, David, to thank you for your extraordinary commitment to the life sciences research and innovation agenda. With that, and apologies for going on too long, now the main act. So I'm going to start off by asking Era Darzi, Lord Darzi, chair of the AAC and member of the NHS board.
Thank you very much, Tim. Thank you also for doing this and getting us together. I'm going to start saying a few nice words about David too, considering his last attendance at this board. David, you've done so much. I'm going to focus on four things which are huge in the history of the NHS. You are the first chair who successfully negotiated the best financial settlement for the NHS at NHS's 70th anniversary. That is something you should always be very, very proud of. You're also the only chair the NHS had leading it through one of the worst pandemics in this century. And you did that by aligning NHS England, NHS Improvement. Andrew said that last night. And that alignment, the recognition, how you set the NHS for battle was very unique. And you successfully did that. And you led this whole team here through one of the most difficult times of the NHS. So we're all grateful for you, not just as a board member, but as a clinician who works in the NHS. So coming back to Tim, I mean, Tim, one thing we all know, you're a clinician too, quality in health is a moving target. The reason it's a moving target, because scientific discovery is always ahead of us and we're always behind it. This paper that Tim has put together is recognizing that the NHS is the only organization that could create value out of science in this country, both health value and economic value. And the NHS did that in the first 50 years of its life by doubling life expectancy of mankind, certainly in this country, in the last 100 years. As we move into this century, technology and science is adding life to these years. And that is really what we talked about earlier at the board this morning. So this is a no-brainer from my perspective. And the NHS is the perfect single payer system. And may I just add one other area that I think it's critical that we change our rethinking how the NHS exploits science, which is what we learned from COVID. What we learned from COVID is, although we had a fast pandemic of infectious disease, the sad fact was that we were living through a number of slow or silent pandemic. whose sad fact is they had the biggest burden of fatalities and complications related to COVID. So we need to refocus the system on what I call on preemptive health. Essentially, how do we take public health? Science is there to identify what I call disease states in which the patient has a positive for disease, but negative for symptoms. We need to proactively identify people, and science will help us improve not just their health, but also the quality of their life. So, Tim, great paper. It has my full support, and I hope we exercise, each member of the NHS exercises this amazing vision for the future.
Thank you so much. I'm going to turn now to the Regis Professor at Oxford, John Bell.
Yeah, terrific. Thanks, Tim. And can I just add my thanks to David, who's been a fantastic supporter of this life sciences agenda, both before he became chair of NHS England in a previous life, but certainly during his time here. And it's been a really successful time. So we've had a program focusing on life sciences in the UK now for over 10 years. And the reasons that we thought this was something that was crucial was because we all know that the innovation that actually makes our healthcare system more effective almost all passes through the commercial sector before it gets to us. And as a result, that relationship with the commercial sector is actually one of the most important interactions that we can have as a healthcare system. And in the first iteration of the strategy, I asked the industry members of the working group to identify 2 or 3 areas that would actually be likely to expand over the next 20 years, and to which they thought the industry could make particular contributions. The first 2 are relatively easy: the space of data, which you've already talked about today, and which is obviously a crucial piece. The second one is genomics, where the UK have got a particular play. But interestingly, the third area that they thought they could contribute most to was the area of prevention, early diagnosis, and population health. Now, that's a bit of an eye-opener, because I suspect most people don't believe that the industry as a whole has an interest in those domains. But the truth is, they can recognize as well as we can, that's the direction all healthcare systems need to get to. And they are going to bring to the table the tools that will allow us to do prevention, early diagnosis, and population health in a way we've never done it before, and hopefully make it much more effective if we're willing to lean into that. And the list is a long one, but you know many of the tools that we're currently using: ctDNA for the early detection of cancer, polygenic risk scores for the identification of risk, which will allow risk-based screening rather than age-based screening, the ability to use novel interventions to move the therapeutic paradigm much earlier in the course of disease, as Era has suggested, is going to be a crucial piece of the puzzle. And of course, many of these things are coupled together in the project which we're currently running alongside the NHS for Our Future Health, which is basically a 5 million participant sandbox to test out all these tools. So I think one of the things we've done is we've persuaded industry that actually they need to focus on what healthcare systems need. And that's their big commercial opportunity. And we need those things in spades. We need prevention, we need early diagnosis, and we need population health interventions, not just interventions for rare disease. And that's where we push this agenda. So look, that's good for me. Thanks, Tim.
John, thanks so much. Matt Whitty, the CEO of the AAC, I'd love to hear your thoughts.
Thanks very much, Tim. One point I'd just like to add to what John said about the life sciences vision, that alongside the focus on prevention, there's a really strong alignment with the clinical areas identified in the life sciences vision, with those areas identified in the Core 20+5 framework to identify healthcare, to address healthcare inequalities. So we know that we can make a massive difference for healthcare inequalities around cancer, mental health, and cardiovascular disease, and there's a really strong alignment there that I think is an important message not to lose, particularly because this is a really strong unifying theme when I'm out talking to patients and staff working in the NHS. And we know that research and innovation is going to play a key part in addressing these alongside the prevention agenda that John and Ara and yourself, Tim, identified. At the last board, we went through the Accelerated Access Collaborative's 5 priorities, so I won't go through these again in detail to talk about our work, but just as a very brief reminder, we're really focusing around 5 priority areas. So firstly, providing a clearer articulation of NHS needs, which we call demand signalling, and matching this to a systematic search for solutions, which we call horizon scanning. And so this is that the NHS can plan and prepare for the next generation of innovations and make sure that the adoption of these, they are ready for the adoption of these in the highest priority areas for our patients. So we're developing this work throughout 22-23, aiming to identify more of the innovative solutions, such as Grail, that we'll hear a little bit more about later from Professor Peter Johnson. Secondly, we're looking to increase the diversity, scale and speed of research, so the NHS can have the clinical evidence that better reflects our population in the UK, and we've got such a strong academic sector in the UK. This is a real area of strength for us internationally, and I think we need to move a lot of the conversations about sort of competition that we see between universities or different institutions within the UK to recognising that we are in a global market for these, and the more research that we can get done in the UK, the more translatable that research will be for clinicians making decisions with their patients. We've got a joint programme of work underway with partners in the National Institute for Health Research and the Department of Health and others on the future of UK clinical research. Thirdly, we've got programmes to support the uptake of NICE approved proven innovation in the NHS. So this covers medicines, medical devices, diagnostics and digital products. We saw at the beginning Amanda mentioning the MedTech funding mandate and showcasing some of the technologies that are supported in from April in that programme. One example from the first year of that programme was placental growth factor based testing. So this is a life-saving world first test for pregnant women, which can quickly rule out preeclampsia. So this means that women who would otherwise be admitted to hospital for a few days of observation can be quickly and safely sent home. And the policy last year helped scale from just 2 NHS trusts adopting that technology in 2019 to over 3/4 of maternity units adopting it as well today. So we can scale things in the NHS. And fourthly, we can't do any of this without supporting our NHS workforce to champion innovation on the front line. So we have now over 700 staff who we're supporting through our Clinical Entrepreneurs programme. And this is a programme where we are enabling staff to develop their frontline solutions to problems that they can see through mentoring and support and working with other people who've scaled such innovations before as well. And that programme's having a real impact. And we're also working with Health Education England and other partners to further develop workforce support programmes specifically focused around the adoption of innovation. And fifthly, continuing our collaborative approach to transforming patient care through commercial deals. We work really closely with Blake Darkin team, who you're going to hear from in a moment, and I won't go through the more deals as Blake will be able to do that. So that was all that I wanted to say.
Matt, that was the terrific comments, and I particularly highlight your comments about the solution to health inequalities and the hinge here with research and innovation. Next up is Blake Dark. So with all that build up, Blake, for all your successes, I'm really interested to hear what you have to say.
Thank you, Tim, and it really is a pleasure to be here. And I'm a little bit red and embarrassed, frankly, but let's get on with things. Look, I just want to reassure the board, first of all, that our commercial medicine priorities are clinically led, and they're aligned, of course, to our North Star, the NHS long-term plan, linked to the life science vision and Core 20+5 you just heard from Matt. Our priorities are focused on improving population health. You heard that from Sir John Bell in key disease areas, but also improving outcomes for patients with a range of rare diseases and also more common diseases, but critically ensuring we get efficiency and value for the NHS and taxpayers, and that is critical. We collaborate, of course, every day with our health system partners. We don't operate alone. Particularly at NICE and MHRA, we capitalise upon innovations that come across. For example, if I just pick something, the NHS has been able to work with NICE to agree a number of early access deals for cancer treatments approved through the Project Orbis route since the MHRA joined the International Licensing Partnership last year. It's one example of many of how we've collaborated as a 3 to make this innovation come through. The NHS, frankly, now has a proven track record of adopting new treatments over the last 3 years. It really is no longer extraordinary for the NHS to announce either a world first or a first in Europe access deal to appropriate innovation at responsible prices. I'm pleased to report that the commercial medicines activity is enabling the NHS and our clinicians to secure those innovations. And I'm going to first start with population health and give some examples. In atrial fibrillation and stroke prevention, we have a national plan to accelerate the uptake of direct oral anticoagulants, and that could see as many as 600,000 more patients receive treatment over the next 3 years, with the opportunity that delivers of preventing tens of thousands of stroke events and the impact that that has on the healthcare system as well as the individuals themselves. In cardiovascular disease, our agreement, our deal for inclisiran, creates the opportunity to prevent thousands of CVD events this decade as well. And in cancer care, working very closely with Peter Johnson, our agreement with GRAIL to undertake the world-leading pilot programme of its diagnostic blood test should support earlier detection of cancers, which will be a huge step change for those patients and the treatment that could come along. And while I mention oncology, please let's not forget the Cancer Drugs Fund. It's a partnership we have with NICE that's enabled 75,000 people to receive access to one of 90 different cancer drugs over the last 5 years. So moving from population health to maybe rare conditions, we're particularly proud of how we've been working in this area too. We've been able to demonstrate, just with a couple of examples, where we've transformed care for people with the genetic condition spinal muscular atrophy, SMA. In less than 3 years, NICE and the NHS, using commercial capabilities, have secured access to all 3 available treatments for the condition, and means there's now an innovative drug available for individuals and our clinicians with SMA for types 1, 2, and 3. And I quickly go into uptake, because there's one thing bringing innovation and getting access, but we need uptake, we need usage. And of course, there are good examples of rapid uptake, and the best examples are where those align with clinical priorities and of course patient need or significant efficiency gains, whether it be at the nursing level or at the clinical doctor's level. An example is the 5-minute breast cancer jab, Phesgo, and the cystic fibrosis triple therapy, Kaftrio. They've seen world-leading uptake across the NHS, benefiting thousands of patients. And we know that because the companies tell us. For cystic fibrosis in particular, where prevalence of the condition is second only to the US, 9 in 10 people with CF in the in England now benefit from access to this new generation modulator therapy. And the recent license extensions that are coming through, granted incredibly speedily by the MHRA, now enable children as young as 6 years old to benefit from Kaftrio. But of course, that's population health, that's rare disease, that's uptake, but there are also personal stories around these. Our commercial capabilities have been the enabler of life-changing treatment being received by Arthur Morgan, who at 5 months old was the first baby to receive the one-shot SMA drug Zolgensma. 7-year-old Kate Farrer was one of the first young people with cystic fibrosis to receive Kaftrio. And our recent agreement for the gene therapy Limveldi will enable more people like 11-year-old Joe Elson to receive the life-saving metachromic leukodystrophy injection. We're putting a record number of treatments at responsible prices into the hands of frontline NHS professionals, allowing them to provide the best possible standard of care for their patients. Medicines have an important role to play in addressing many of the challenges associated with service recovery. They cover a broad range of issues from health inequalities through to environmental impact, the medicine supply chain. But of course, we also have to be prepared for the inevitable growth in areas like antimicrobial resistance. For me, this is an area I'm personally incredibly proud of the team and all of us, and how the NHS and NICE have shown global leadership with the development of our pilot programme there. So to finish, let's be frank, a lot has been done, but there's a lot more to do. By working with organisations represented here, with the frontline teams who work every single day with patients, with industry, with government, and many, many more, I'm confident that the NHS will continue to be commercially astute, pro-innovation health system that delivers value for the taxpayers and does the very, very best for patients to improve their care and treatment. Thank you.
Blake, thank you very much. That did not disappoint. Just saying. June Rain, the CEO of MHRA. Yes, you are here. There you are. It's all the stage is yours.
Well, thank you very much, Tim, and good afternoon, everyone. As the UK's independent regulator, the MHRA is wholly committed to supporting the success of the life sciences vision in the NHS and to realising the full potential of this amazing vision as an enabling regulator, no longer a watchdog. And I'll highlight briefly three main ways. First, in terms of accelerating access to innovative products via our end-to-end integrated pathway, the Innovative Licensing and Access Pathway, which is attracting huge interest and is already delivering via the target development profiles that we're co-honing with NICE and our partner organisations. Secondly, and importantly, safety, our first priority, will be enhanced using real-world evidence, new tools, methodologies, and importantly, putting patients and their perspectives at the very centre. And thirdly, in supporting the ongoing evolution of our clinical trials regulatory framework, which we are about to enhance to take full advantage of our new freedoms, and to do so for medicines and medical devices. We are determined to operate in partnership with the NHS as a learning organisation and to be a full partner in everything the NHS aspires to do. I'll finally just say huge gratitude to you, Lord Prior David, because you were instrumental in helping us start this transformative journey, and I'm enormously grateful to you.
June, thank you so much. Terrific. We're in the home stretch now. Sam Roberts, the CEO of NICE, and David, I would say I think she's still in the family.
Exactly. A distant cousin is what I am. So thank you, Tim. Hard acts to follow, but briefly to say, NICE's role is thinking about, do we get the best value for the taxpayer by advising on clinically and cost-effective care? And so where things are going well and where we think we've got more to do. So where things are going well is 95% of our completed technology appraisals come to a positive recommendation, which means in 95% of medicines we're saying, yeah, absolutely, people in this country can benefit from those. And that has changed radically over the years, largely due to close working relationship with NHS England and Blake's team. So I think that's a huge success story. Where we've got more to do. One is working with MHRA to make sure that time between when MHRA says, yep, good to go, and we say good to go, gets narrower and narrower, because we know every day counts for patients and people getting new care. So that's one thing. And then the second thing is we would love to be your kind of first port of call on diagnostics and digital products, because if you're a health system that's thinking about prediction and prevention, then we really need to have a key part in you understanding what are the most clinically and cost-effective technologies, not just medicines, everywhere. So we have programs there, but I think it would be great if we work together a bit more closely in understanding where you think the big innovations are coming from and where we can kind of provide advice. So good start, more to do. And David, we will miss you. What a phenomenal leader you are. And thank you for everything you've done.
Sam, thanks for that great comments and challenge. Last but certainly not least, Professor Peter Johnson. Peter.
Tim, thank you very much indeed. And I think my job today is to highlight just a few of the areas in which the innovation agenda has worked well and where we see it going in cancer. Clearly, there's a very broad program of work in this area, and Blake and Matt have already highlighted some of the therapeutic innovations which have been brought through, and things like CAR T-cell therapies and proton beam therapy are areas in which the very rapid adoption of new technology is feeding into treatments. But I wanted to focus today specifically on the area of diagnostics, because I think this is a very strongly emergent area and one in which we're seeing a huge amount of activity. And certainly in terms of the new ways of working post-COVID in response to the pressures of the pandemic, we've brought in a number of innovative technologies. We've brought in the colon capsule endoscopy, the pill which you swallow, which passes through the bowel, taking pictures as it goes. as a means of taking some of the pressure off the colonoscopy waiting list for the diagnosis of bowel cancer. And about 2,000 of those capsules, we went from a standing start in the depths of the pandemic to around 2,000 of those having been used already and in about 40, 50 sites across England. Secondly, the Cytosponge, which is again a small pill with a sponge inside it, which you swallow with a bit of string on the end, and the sponge expands in the stomach, and then we can withdraw it up the lining of the esophagus, the gullet, to look for early precancerous cells. And again, we went from a standing start from the research evidence that we had to around 2,000 of these that have been used across England since we started that pilot program, again to take the pressure off some of the waiting times for upper GI endoscopies. The building on our clinical research infrastructure has been a big strength, and clearly we've spent 20 years developing the cancer research networks, and I think our partnership with GRAIL, in which again Blake and Matt played such an instrumental part, is an excellent illustration of how we've brought this into practice. And from having signed an agreement just before Christmas in 2020, we opened the study in the summer of last year, and we've already recruited 70,000 people into this study in 6 months of accrual, and are on target to recruit 140,000 people to a huge randomized controlled trial to test the effectiveness of this particular blood test, looking for chemical alterations in the DNA in blood as an early marker of cancer development. And what's been really fruitful in that is the partnership with NHS Digital, who have enabled us to identify the people to invite, and which has allowed us to skew the invitation specifically to those groups in the population who are often underrepresented in research trials, particularly people at the worst end of the deprivation spectrum. So that as we've monitored the accrual to that trial, we've seen that we've actually managed to even that out, and we're getting fantastic uptake of that technology right the way across the spectrum, and not just in the better off groups who often feature much more heavily in research studies. So that will generate an enormous amount of evidence about faster ways potentially of diagnosing cancer. And I'm delighted to say that as a consequence of that partnership and that activity, we've got a regular stream of other diagnostics coming to us to wanting to work with the NHS in early cancer diagnosis. With the good offices of the Accelerated Access Collaborative, we've run already one competition to look at ways of accelerating new ways of diagnosing cancer in pilot studies of technologies which are ready to go, whether it's artificial intelligence to analyze chest x-rays, or whether it's new ways of looking for circulating DNA to see whether we can diagnose cancer not by doing a tissue biopsy but by analyzing the chemical changes in the blood, and a variety of other new diagnostic technologies. We've run one round of that already during the pandemic, and we've just announced a second round, and again lots of interest coming in there from across the spectrum, large and small companies both very interested in working with us. For the future, I think there are huge opportunities, as John has already highlighted, in making the most of our capacity to link data. We're already producing enormous amounts of information, for example, about vaccine effectiveness in cancer patients during the pandemic by linking together all the different data sets that we have, vaccine data, PCR data on COVID, and hospitalization data. We've got huge opportunities in the genomics area, and again, working very closely with Sue Hill and the genomics program to make sure that we're maximizing the uptake of that technology to enable us, firstly, to identify those populations at higher risk, and secondly, of course, to do some of the precision medicine. And finally, to put some real force behind immuno-oncology and our ability to harness immune responses to cancer, and making sure we build the infrastructure for the future for the readouts of those sorts of trials, which I think is going to be critical to bringing new investment in from those companies which are interested in investing in immuno-oncology studies for therapeutics. So a broad program of work, and I have to say the collaboration between the different agencies that you've heard from in this segment this afternoon has been incredibly fruitful, and as I say, with David leading the charge on this one, and has been a huge champion, and has brought me more diagnostics companies to talk to than I thought existed.
Peter, thank you very much. Chair, it's my pleasure to turn the podium back to you, and just praise the extraordinary work of the group assembled here, and thank you again for your leadership, David.
Thanks very much, Tim. Just before I bring Richard and Wal in, maybe just a question for John Bell, actually. Just if you look forward, 2 or 3 years, John, or 5 years, how important is genomics going to be as sort of a shaper of the way healthcare is delivered?
So, David, it's a really good question. I don't think there's much doubt that it's going to be used in all aspects of the treatment paradigm. It'll be used for prediction, and it'll be one of our greatest tools for prediction as part of the public health and prevention agenda. But it'll also be used for specific diagnoses particularly where genetic variants are highly penetrant. And of course, we've already seen a remarkable explosion in programmable therapies based on genetics. So the RNA technologies for vaccines, the siRNA technologies for turning off genes that are producing various forms of risk factor in the body, they're likely, I suspect, to be the new biologic which dominates the therapeutic arena for the next 20 years, a bit in the way that antibodies have really dominated the last 20 years. I think the next 20 years will be genetically programmable therapeutics going forward. So it's really hard to imagine that it's not going to be it won't be the only thing we do, but it'll be a really important pillar.
Thanks, John. So Richard, then Wal. Richard.
Thank you, David. David, and having heard that series of very good presentations, I can quite clearly see why you focus so hard on this in terms of its transformational capacity for the health service. The question actually is, and John, we met a couple of weeks or so ago. For me, it's a bit of a simplistic question and probably quite difficult, therefore. But what are the main practical challenges or issues that you face? Are they challenges in terms of prioritization of either the medicines or the potential range of interventions that a very creative and innovative world is increasingly coming up with? So is it how we prioritize those that we choose to essentially introduce to our population? Or is it an access point in terms of who do you access, how well do we access to get sufficient, for instance, research populations that we can test interventions on? Is it a priorities point? So as you come at the systems, as you come at the health service, is it actually a question of our own internal priorities? And earlier in the board, we've been talking about the pressures of UEC and elective backlog and so on. So can you give me some insight into what you think the most practical of the challenges are that inhibit our ability to see real acceleration in this space? Because I think that the case you make and is made is a very strong one in all the presentations for why this is a really important area of focus. But what are what's the most serious practical difficulty?
Yeah, so I think that the two things that I would highlight are things that I think are underway getting to be fixed at some level, but there's still important issues. And that's the first one is making decisions about the priorities. So the NHS needs to be better at knowing what's out there in the way of innovation that's coming in our direction and reaching out and grabbing it and bringing it into our system to do what we want it to do, not what perhaps the commercial body wants it to do. And that, we've been starting to orchestrate from a strategic perspective, the dance. So up to now, we've just let the music play and done whatever we could do. Now we've really got to, I think, define what the dance is going to be and who we want to dance with. And then the second one, which is that, the NHS England has never really leveraged the fact it's a 55 million patients pool of people. I mean, I know it sounds odd and you'll think it's weird, but it isn't weird because somehow organizationally we've fragmented it into about 260 little bits. And as a result, we can't use the leverage you get as a massive consumer of healthcare innovations. And when you get into population health, we really want this to reach all bits of the NHS. And I know Matt and Era and the team are thinking really hard about how to solve that deployment issue, because the speed at which, once you've decided you've got the data that shows you've got a transformative population health intervention, you don't want to wait 3 years before people get it in the south of England or the north of England. You want it to go out there to everybody, and you don't want to leave that decision to a whole load of local quangos. That's got to be, it's got to be put in with some direction. I'd say if you could fix those two things, Richard, you'd be making massive progress.
Okay. Thank you, John. Thanks.
Yeah.
Well,
thanks, David. I'm sort of thinking how to frame this question and who to direct it to. I'll go for Tim, as he's been comparing, and you can decide who you want to direct it to. So I was looking at Flywheel that's in the paper and thinking about the comments people were making in various different presentations were all, extraordinarily good and to the point. But the comments making around population health, and going upstream to prevention. And some of the work that I was doing with my previous hat on, being chairman of the Guy St Thomas's Foundation, addressing programmatic things like, childhood obesity or multiple long-term conditions. What we found was actually, as we're doing our horizon scanning, you are ending up working with really small organizations, almost street by street. And in your flywheel, you've identified people who are sort of, for want of a better word, big. And so John just mentioned, big interventions with 55 million people across the country in England. Actually, before you get there, sometimes you have to do the work at very local level. So multiple long-term conditions, for example, where there is no direct intervention. You need to figure out how people go from one condition to many. And that pathway is not very well understood. And doing very local, hyper-local, in fact, involvements, and then realizing it's things like socioeconomic conditions that determine whether or not you progress from one to many different conditions. I'm wondering, these small, fragile organizations, how will you actually bring them into the fold before you then scale? Because they are really small, and some of them are doing some really cool work, and they're neither academic institutions, nor are they commercial organizations, nor are they sort of patient or parent-led.
David, shall I respond now, or yeah, okay. Well,
yes.
What a terrific question, and I'll just say two quick things about that question. One is to John's question about the spread. What I think you're describing is a special case of the spread issue, a really, really important case though, and like all challenges, I try to reframe them in my head as an opportunity. And the fact is that because we have a health and social care system, and much of the ecosystem that you just described is actually in the social care side, those small organizations, it is a challenge. Well, you're no question about it because of the scale issues that you so rightly pointed out. But it is actually also an opportunity because there are very few other places that have even the potential to connect up the health and care sides of this. That is not to diminish the logistic, very real logistic challenge, but I do see we're actually in a better position to address that than a lot of other countries are. But it will not be easy to make progress on.
Thanks, Tim. Julian and Peter Johnson. Julian. Julian, you're on mute, Julian.
I was just going to answer how to join up a few of the agenda items, how I think we need to exploit some of the other things we are doing to make further progress on how we spread innovation fast. Because, I mean, actually the creation of Tim's role, the bringing together of E&I, I think is a really critical part of this. It gives us the chance to look at the whole system and all of our levers in one place. The legislation we are just putting through and the bringing together of systems, and actually, I think something we haven't spoken about a lot, but which is how do we really provoke scale provider collaboratives so that we can honestly get learning spread. And I think to John's point, it isn't just 220 individual organizations, and we have got to think harder how we use our marginal funding to kind of drive that innovation. And I would actually give the example of how we have put incentives into the GP contract to promote the take-up of inclisiran. I want to spend, as the finance director, more money on that medicine to get better health outcomes, and I think we can now use all of our levers of value, and that is what we need to do. And then data. I mean, data is going to be critical, right? And I think I can't remember who it was who gave it was probably Peter, the example of how do you promote fast uptake, because you can identify the people specifically. Now, as Tim would remind us, we've absolutely got to protect individual private patient data that we used for care, but how do we make that data available to clinicians at, in primary care networks, in our provider collaboratives at system level, that they can make really good clinical decisions and identify who we should be targeting very specifically. And again, I think the legislation that is currently going through, and then the changes around HEE, NHS-E&I and NHSD are really critical to how we pull all of this together whilst all of the safeguards are properly in place. And then of course investment, where I will headline, actually, fair play to the department for the funding they've secured to invest in trusted research in environments, so we can keep going at this harder. And I know, David, you and John are involved in various projects to look at how we speed up research. But I think there's lots of things we are doing to structurally address the challenge of going harder and faster at really effective innovation and spread.
Thanks, Julia. So Peter, then David Bean. Peter.
Thanks, David. Yes, to Wold's point about the small scale organisations and how you work with those, I would highlight the work, I think, of the Cancer Alliances here, which have really matured in the last 2 or 3 years. And what we have in there is some dedicated resource for people to really understand the landscape of their local population, what the needs are and what will work. And we've seen some really nice examples as we've recognised the deficit in the number of people who've come forward, for example, with prostate cancer during the pandemic. Some of our alliances have done some really innovative work of case finding, getting out amongst the relevant community groups, working with these small organisations to make sure that we're getting into those groups of population where we really want the message to get home. So I think absolutely we need to work at the macro level and make sure we've got the data linkages and the big national work. But our ability to reach into these communities through things like the Cancer Alliances, I think, is going to be critical also to success.
Thanks, Peter. David?
David, Tim, thank you very much. I enjoyed reading the paper, and I thought the presentations were even better than reading the paper. I think this is really terrific work, really very, very exciting, and congratulations to all. What it's made me think about, though, is we talked about ICSs and ICBs and the importance of collaboration at the local level, and I think this is an example of the importance of collaboration in a different way, but at a different level, between public and private, between research and delivery, etc., etc. And it's just made me think about Gordon Messenger's review about leadership and the workforce we need to ensure that we deliver on these agendas, and just the very range of skills. Leading across complex systems, I think, requires a different type of leadership than perhaps we've enjoyed hitherto. And one of the things that it's excited for me is just thinking about how we develop leadership for the kind of work that is being demonstrated here, the importance of people working across boundaries, of collaborating to bring products to delivery. And what are the skills that are going to be required? The question to John about what is the next 5 years going to look like, and it strikes me all the colleagues that have talked about how they've brought some of these examples forward. A lot of the skills that they've demonstrated are the skills of collaboration, but also the kind of resource investigation skills of just knowing what's out there in this complicated landscape and bringing them forward. And it's just as worth thinking about what the future workforce requirements are going to be to ensure we can build on the success that has been demonstrated by the presentations here. So just some reflections there, that it's not really a question, but really, really exciting and full of admiration for the work demonstrated.
Thanks, David. I think Matt maybe want to come back, maybe pick up some of the points you've made. Before he does, though, Munir.
Thanks. I just want to pick up on the workforce issue as well. This is really exciting. It's great to see this after 2 years of being on the board and so on. But you know, I work with colleagues in the NHS. They're very keen to be able to contribute to the research and innovation agenda, but they don't have time. The delivery of care obviously takes precedence. So we need to make sure that we have a workforce that's adequately trained, but also has the relevant amount of time to be able to help making sure that this is a success.
Thanks, Munir. That is a critical point, of course. So look, there's no answer to that, I think, on this call, Munir, unfortunately. But I think, Amanda, it's a message that needs to go to a lot of chief executives, that this is really important. And of course, the patient in front of you is always going to take precedence. But Munir is putting his finger on a very important practical point. Matt Whitty.
Thanks, David. Just in response to David's comment. So over the last few weeks, we've been going out through the to the academic health science networks and speaking to local system partners. And one of the really there are three really key themes that are coming through when we're talking to people working in ICSs. They're saying, and this resonates really well with the healthcare inequalities agenda. They're saying, what's available now that can help us reduce these healthcare inequalities, and how can we get implementation support to implement it? What's coming through the pipeline, and how can we prepare for those things coming through now? And how can we help to kind of shape the future things coming through so that they're more targeted about what we need? And that's a really, really strong message. So the healthcare inequalities has really helped focus the kind of the clinical priority areas, and they know that research and innovation is important, and they're just looking for our help to do that. And we're looking for their help to tell us how they can what support they need.
Amanda, then I think I'll probably wrap it up. So Amanda, over to you.
Very, very briefly, David, I just think, if I may, I think this whole conversation is really testament to the leadership that you've provided over the past few years, along with all the partners on this call, because it strikes me there's three really big things I've heard. This works when we think about research and innovation for a purpose. It's not just an end in itself, and that's been such a consistent theme through this discussion. It's meeting real needs now, as well as those that we've identified as the big things for the future. Secondly, and that's of course what the life sciences vision absolutely does, it ties that absolutely to purpose. Secondly, that it only works when it's joined up, and what that's so true at national level, looking at the colleagues we've got on this conversation, because you know, if it wasn't for June, if it wasn't for Sam, if it wasn't for partners in the industry, you know, you just couldn't do it. And I think replicating, I think David made a brilliant point on this, you know, it's replicating that partnership approach then at all levels within the NHS. And thirdly, it's creativity and approach, not just in what but how. So things like the managed access deals, you know, the way that we've been able to work in partnership with industry to be able to get the right deal for the taxpayer, but also get rollout at pace, things like the Grail trial and that innovative approach to that, just brilliant examples of it. So it's the enablers then that need to, so that partnership needs to continue, and under Richard's leadership, I know it will. I think we've talked about the importance of data, we've talked about the importance of digital, and we've talked about the importance of this being absolutely knitted into the ICSs from day one. And I know, as other colleagues have said, there's a real enthusiasm for that, because this is meeting the real needs now. And certainly it is my belief, and I know others share this, that if we really are going to tackle the great challenges of the future, we will need this kind of research and innovation at the heart of our response.
Thanks for that, Amanda. And your personal support for this is don't underestimate it. It's really important. So look, maybe I could just conclude by saying that whenever I sit around the table with our guests who are here, who joined us today, and with Tim, you know, with whoever it is on the other side of the table, around the table, we have a world-class team here. No one else can do what we can do. We can put the whole ecosystem together in a way that no other country in the world can do. So let's really go at it if we can. And thank you all very much. And Tim, I'm looking at you especially on this, you know, from the NHS side, to really drive this forward over the next couple of years. But thank you very much for sort of orchestrating this discussion today. So look, our guests can leave now if they wish, or they can, if they've got nothing better to do, they can stay. It's entirely up to you. But thank you all very much. I just want to go back before we wrap up the main board meeting, back to the money, if I can, Julian, and in particular, next year's money, the 22-23, because this is obviously crucial to us if we're going to deliver the revised long-term plan and the various objectives that the government has set for us. Do you just want to give us some concluding remarks on that?
So just a couple of things. Firstly, the Chancellor announced that he had doubled the efficiency rate for the NHS, and I just want to be clear, at the weekend to 2.2%, the underlying efficiency rate. I just wanted to be clear that that is not in addition to anything we've already asked the NHS to think about. Secondly, we've set a pretty challenging set of targets in planning guidance for the NHS. We recognise the inflation issue, but we are not going to make the ask overall more difficult. We have to think how we deal with the inflation ask without that just simply being another sort of additional pressure straight into our frontline services. Thirdly, David, to your question, that we are going to have to think about how we are phasing now some of the investment we have planned. I mean, we are, how fast can we go at some of the change in technology? What exactly is some of the phasing we'll have to do actually around some of the innovation stuff we have spoken about? How fast can we roll out some of the new prevention programs? So I think the challenge for us is how some of that is going to have to be rephased over the course of this year, whilst we frankly grapple with the core recovery and the expansion in some of our core services like mental health, which we have absolutely got to protect.
Thanks, Julian. And Amanda, do you want to add to that at all?
Thank you, David. No, I mean, I think everybody is absolutely aware of the importance, of course, of us being able to make good use of the funding that we have been given. And I think we've heard a really great presentation from Jim earlier on, which evidences hopefully exactly that in relation to things like elective recovery. We've also heard about some of the kind of very real pressures on the service. We've talked about urgent emergency care. We've talked about maternity particularly. And I think in all of the way that we're thinking about next year, we're very, very mindful of the scale of challenge and how tough it is if you are actually working in one of our hospitals, in one of our ICSs, in one of our primary care networks, if you're in an ambulance service, if you're working in community. And our job, of course, as part of this is to, as it is for all leaders in the health service, is to get the balance right. Because, ultimately we're here to do the best possible for our patients. And that means making sure we've got access as fast as possible when we need it, make sure we are going up that recovery journey. It also makes, it's absolutely about quality. And we've seen that particularly in the conversation about maternity today. But it's also about making sure that we have got, our eye on delivering our financial plans. And that's why Julian in particular has spent such a long time trying to make sure that in terms of being very clear what is passed down as part of the allocations to the NHS to get on and plan for, we're clear about that, and then clear separately about when new pressures arise, how they're being dealt with in a way that tries to minimise the impact on our colleagues who are actually out there doing the business. And I think that is the heart of what Julian is saying. So I think really helpful for us to be able to clarify for anybody who is worrying about it, there is no additional expectation of efficiency over above what's already been shared at this point in time, but there are implications, inevitably further asks on us. So I think Julia set it out very clearly, but I think it's just helpful for us, David, to be able to be to have this opportunity, I guess, to make it clear that we're certainly very thoughtful about the amount of about the scale of the pressure on the NHS at the moment, but we're also absolutely determined, all of us collectively, to make sure that we are doing our absolute best to support the service to respond to it in the magnificent way that the NHS has absolutely got a track record of doing.
Thanks very much, Amanda. Well, look, I think the next 4 or 5 items are just for noting, and so just before I hand over to Richard to have the last word, if you like, just to say that to Richard and Amanda, the senior executive team and the board, as you continue to slide down the banister of life, may all the splinters in number 10 and the Department of Health be pointing downhill. And all the very best to you. Over to you, Richard.
Well, thank you, David, and thank you for that that image. I may be coming for treatment in my nether regions if they're not pointing in the right direction. Look, as I take this on and take the baton from you, I recognise how daunting a challenge it is, and that it's a very demanding role and one that I'm humbled to take on. In the last 4 to 5 weeks, I've done around 80 different meetings and sessions with a range of people across the system, whether it's providers or provider collaboratives or GP practices, ambulance service or ambulance service leaders, ICS leaders, ICBs, public health officials in local authorities, people leading our reviews, Gordon Messenger with Linda Pollard or Claire Fuller, so a range of different people across the system. And I have to say, you know, I am always absolutely delighted by the commitment and in many ways the brilliance of the people that I'm coming across. It's a really able group of people who are working in this joint endeavour. That's not what I wanted to talk about. What I wanted to say, David, was just to thank you personally for how you have helped me approach this role in your various personal briefings to me and the views you've shared, and also the introductions that you have made to people who've helped me sort of begin to immerse myself, although I realise I'm probably only a couple of inches under the surface. But in doing that, sharing of your experience with me, you've shown me actually both your deep expertise and the passion you have for the NHS and for what it stands for, but also your questioning and your views as to how the NHS might best evolve and your vision for what the NHS might become, and perhaps best exemplified actually by that last hour, that last 50 minutes or so, which is a truly brilliant, I think, discussion and exposition of the potential of life sciences to transform the way we think about and intervene in the health of the people, the nation here. And now I know all of your board colleagues will join me in expressing their huge appreciation of the leadership you've shown, and I pick up in particular our Lord Darcy's comments around particularly the courage everyone showed, but you as chair and showed in terms of leading through the last 2 years, which has been a really, really challenging, truly challenging time, and helping guide us through the pandemic. So on behalf of the board, I express my deep thanks to you. I mean, if they can do it better, they've worked much more closely with you, but just to thank you for the, as I say, for the way you've helped and guided me in here. And I recognise, to quote someone from last night actually, at dinner, that I have huge shoes to fill in following you, David. So thank you very much. And I will do my best to follow the example that you've set. So thank you very much.
Well, that's very kind. Thank you very much, Richard. And I think, unless there's any other business, I think we'll close. So thank you all very much. Thank you.